Kia ora everyone and welcome to this Goodfellow webinar on insulin intensification in type 2 diabetes. My name is Dr. Grace Lee and tonight I have the pleasure of talking to two fantastic speakers. We've got Dr. Brandon Orr-Walker, who is the Clinical Head of Endocrinology and Diabetes at Middlemore Hospital. We also have Dr. Brian Beattie, who is a general practitioner and the Medical Director of the Royal New Zealand College of General Practitioners. Over to you.
Great, thank you, Grace. So my name is Brandon Walker. I'm an endocrinologist, and pleased to see my friend Brian up from Wellington today. So happy to see you, Brian.
Yeah, no, good to see you, Brandon. Should be an interesting topic. I think it's very, very interesting for general practitioners in particular, this topic.
Yeah, absolutely. So a recent audit in Auckland looking at general practice-based diabetes care showed that about 25 years ago, the median number of patients in practices was about a dozen. And now it's over 100 in practices, obviously a large variation of practice size, but this is now really core business for all health practitioners in primary care as well as in hospital and secondary care settings. I've got some disclosures. I sit on a number of speaker bureau and also advisory groups to a number of pharmaceutical companies involved with diabetes products and diabetes care. And as you'll see in my other disclosures, have been involved in non-pharmaceutical advisories as well, including Ministry of Health, etc. Brian, I don't think you have any specific commercial things to do here. So we've put this as our agenda and overview, and we won't read it all out. You can read it here, but we'll be covering these topics, I think, in this order, and I think we're welcoming your questions as we go, and Grace is going to give us some prompting on that, so bear with us if we can't cover all of the questions in order. So my background is covered on this. I've had a strong interest in diabetes since moving to Middlemore Hospital in 2001 and have been involved in trying to have efforts to decrease diabetes prevalence, so prevention programs right through to integrated care, and have had in the past some involvement in the Ministry of Health providing advice to the then Minister and in the immediate past President of our New Zealand Society for the Study of Diabetes.
So for me, I've been a general practitioner in East Pororua and Cannons Creek for the last 12 years. Obviously, that's an area with a very, very high diabetic burden, in particular with Maori and Pacific. And we're increasingly seeing younger patients being diagnosed in their 20s and 30s with type 2 diabetes. So it is becoming actually quite a burden within the practice, and I think it is becoming a burden across the country for general practice in terms of what's happening at the moment. Also Medical Director of the Royal New Zealand College of General Practitioners and sit on the National Diabetes Leadership Group at the Ministry of Health. I suppose it'd be good to just open with a few general comments about diabetes in New Zealand. I mean, the latest figures we know there's about 250,000 people across New Zealand with diabetes. We think approximately 210,000, 220,000 of those are type 2 diabetes. Now, I suppose the key thing about that is there is no way that specialty services or secondary care services can deal with that burden of disease within New Zealand, which is growing year on year, as we know. So I think it's really up to general practice, and it's really up to primary care to step up to the plate in terms of the management or the day-to-day management of type 2 diabetes. Part of that becomes things like insulin titration and intensification. We know we do have a problem in New Zealand where there's this thing called clinical inertia, which we may tap into a little bit, where we're perhaps slow to add in medication or perhaps to move to insulin or to titrate insulin. And that's one of the reasons for doing this seminar tonight, is to really talk about that and talk about intensification and why it is actually important. The other comment I'd make is we know in New Zealand that Maori and Pacific in particular are starting to develop diabetes at a higher rate and at a younger age. Now, if we assume that there's about 20 years to major complication with type 2 diabetes, someone who is 35 being diagnosed with type 2 diabetes, I think is in a very, very different situation to someone who's maybe 70 with type 2 diabetes, that you're a lot younger when those complications cut in. So for me, I think one of the really, really important messages here, we need to be reasonably assertive in the way we start to approach diabetes, start to think about the individual in front of us, and start to think about what is required for that person now and longer term as they travel through their journey with type 2 diabetes.
Yeah, absolutely, Brian. Just to add to that, I think, the key themes that we've learned is that type 2 diabetes is occurring at younger and younger ages, in particular in those at-risk groups, so that's high deprivation groups and certain ethnicities, and that when it occurs young, it tends to be a more aggressive phenotype or type. And the themes in the literature in terms of preventing harm are that we need to get in early, hard, either with prevention, so remitting diabetes with lifestyle change, or with medical treatment, and we get a so-called legacy effect of doing that. If we try and just leave it to late and have this inertia problem, we're not serving our patients best. So I think, type 2 diabetes is actually a complicated condition, and as you've said, Brian, there's 210,000 people estimated. That's a population as big as all of Hamilton. It's a very large population. It's actually very heterogeneous. It has people that have been picked up through screening activity for diabetes and cardiovascular disease late in their life potentially, and it's got people also with symptomatic diabetes with very poor control with complications, all in that group. So we know that this is a progressive condition, and there's a few key physiologic factors that are worth keeping in mind, and they help us in terms of understanding our therapeutic options. So it's a progressive disease where pancreatic function reduces with time, and that's a key issue, and it's one of the ones I always like to tell patients when I see them relatively early in their condition, is that they need to understand this, and that our need to use more and more treatments later isn't their failure. It represents the increasing needs to control glucose in their bodies. Most of us note that we're becoming more insulin resistant with age, and that's to do with activity, about putting on weight around our middle. And so even if our pancreas could produce a similar amount of insulin as it once did, we are likely to be more resistant to the glucose lowering effects of insulin with time. And the third one, not covered in the slides that are in front of the audience now, is that the liver continues and actually may produce increased amounts of glucose, in particular in the fasting state. And that's one of the reasons why occasionally we have patients who go to bed with fairly good glucose levels, but wake despite fasting overnight with higher glucose levels in the morning. And the treatment requirement for that is insulin to be able to make that control. So these are just some longitudinal schema. They're really a cartoon, I guess, that is just summarizing experience of many of us, and in studies where they have followed people, where there is an increase in both postprandial and fasting glucose with time. Both elements are really important, and the underlying physiology in the lower slide is that there is increased insulin resistance. Early in the piece, there is a compensatory increase in insulin to be able to try and control glucose, but that fails with time with beta cell failure, and so glucose levels further rise.
I suppose the key thing there, Brandon, from a practice point of view, is that over time diabetes does tend to progress as essentially the pancreas winds down, and sugar levels start to go up. So sort of, I suppose, very early on in our treatment or our discussions with our patients with type 2 diabetes in the very early stages, I think it's important to set up clear expectations, or start to really talk about the normalization of treatment down the track, which does or will in a lot of cases include insulin.
Absolutely, and we'll see when we think of some of the factors that create clinical inertia from the patient point of view, that unrealistic expectations or false beliefs about failure on treatment, etc., can be to a large extent averted, I think, by an early discussion of these points. So there's been guidelines around for a long time. Brian and I were, I think, involved with the last lot, and it's a very long time. And to the audience, just to let you know that there are moves afoot to update those with newer treatments, but also in light of new information about treatment. But guidelines here generally are to try and achieve as close to physiologic glucose levels or an individually agreed target. So in our metrics these days, an HbA1c of between 50 and 55 is what we try and aim for. But one's got to take into account a number of factors, and those are obviously some patient factors we'll cover soon, but also being very, very mindful of the risk of hypoglycemia. So if glucose is toxic in excess, you must still have sufficient to keep the brain, the heart, and the kidneys in particular going, as they are obligate glucose metabolizers.
So I think, we need to think of the individual in front of us. And I made the comment about maybe younger patients with type 2 diabetes versus older patients. And I think we need to maybe less stringent with our targets, for certain patients. And obviously there's three groups. There's those patients that are at risk of hypoglycemia. Hypoglycemia is often the hidden thing that occurs. It is detrimental to the patient. It has quite profound physiological effects, and it's something we need to avoid. Patients with limited life expectancy, so as patients become older, I think we can loosen our targets to avoid the risk of hypoglycemia, but also we don't need to be as stringent. If life expectancy for an older patient is shorter, we don't really need to be as I suppose obsessed or things about a very, very tight targeting. Patients with advanced complications such as end-stage renal failure, a whole lot of other things we need to think about, and patients who may have difficulty achieving targets despite intensive management. So I think we need to buy into that a little bit and think about what's reasonable or what's achievable in the context of the patient and their lives and what they're doing. So I think these things are very, very, very profound in terms of the way we treat the patient and the way we set targets for the patient.
Yeah, absolutely. And I think one of the other things which we've covered is that whilst a lot of this talk is talking about intensification of treatment to achieve good control, ironically, in people as they get older who have advanced renal dysfunction, etc., they may actually start to achieve excellent glycemic control on treatment that previously was not achieving that for them, yeah, and be at risk of hypoglycemia. And the reasons for that largely relate to renal failure, decreasing eating, and so forth, for example, in very aged patients. And so review is also important for down intensification of treatments.
Just on that point, I mean, I've recently had a patient who was in her late 80s who was on a sulfonylurea and metformin, and over a period of 6 months became particularly unwell cognitively in the way she was feeling. And we actually stopped her diabetic medication completely, and she felt like a different woman. It was incredible. It was a real wake-up call, I think, for me as a practitioner, that we really need to keep our eyes open for medication, and sometimes the need to perhaps down titrate or back off a little bit on medication as patients get older.
So this talk is going to be a lot about insulin treatment, and I make no apologies for being involved with that. In part, it's because in New Zealand we are very, very reliant on insulin as a glucose-lowering therapy. Secondly, it's actually the most modifiable and titratable and individualizable treatment option that we've got. And we know in our country, where we have a lot of obesity, one of the countries with the highest obesity rates, that insulin often is the only highly effective treatment for a lot of people to achieve the sort of control we're talking about. And so, like anything, I think we can best utilize treatments such as insulin if we really understand insulin. And insulin, of course, is a bit more complicated than most of our medicines because there's many different flavors of it. Yeah. So we have the onset of duration of insulin use, the onset of action, the duration, and that whole ability to up titrate and get up to a limit, and we'll talk about that later on, I think, of increasing dose giving an increased effect. So this schema here really just tries to highlight a couple of things. In the black lines is a cartoon really of normal insulin secretion in the fasted state, and then following a meal. And then each of the colors represents a profile, again somewhat schematically drawn here, of different insulin. So regular insulin, rapid acting insulin analogs, so those are the ones we tend to use a lot now, such as Humalog and Apidra and Nova Rapid. And then the more basal insulins, such as MPH or protophane insulin, cloudy insulins, and the long-acting analogs. And in New Zealand, the funded one is Lantus or Glargine. And increasingly mixed insulins, which have some of those properties of the rapid-acting as well as the longer-acting insulins. And so they're all tools that we can use. At the end of the day, they're all working by working on the insulin receptor with its predictable effects. Okay, so I might talk a little bit about intensification. So I think it's well known to the audience, and I know a lot of you out there are clinicians, that there is now very, very clear evidence, and this started to amass from the late 1990s, that indeed, be it type 1 or type 2 diabetes, that glucose control does affect outcomes for both what we call macrovascular and microvascular complications. And the latest one of these, which is a lot of interest, is covered on the slide here, is heart failure, this very important complication that's been under-recognised, I think, for a long time. And yet, despite this, in fact, we find that there is a large proportion of the population who have diabetes, who are having tests that have actually very poor control. So in my patch, for example, in South Auckland, Counties Manukau, there's nearly 8,000 people with an HbA1c of greater than 75, and that number is fairly unchanging, and any individual who's got that number this year has about a 2/3 chance that they will still be in that same bracket, so very poorly controlled a year down the line. So, you know, these figures are probably replicated elsewhere. I'm not picking on it other than I know those figures.
No, look, I mean, in our practice, we've had a look at our practice. We have about 450 diabetics in our practice of type 2 diabetes, and we have a very, very similar sort of pattern sort of emerging. The other thing we've noticed, and has been replicated, is that those who are younger, maybe in their 20s or 30s, tend to have higher, on average, HbA1cs. And I think that's very, very significant for the potential to develop complications down the track at an earlier age. I think the other thing that's actually pretty key here is the fact this evidence has emerged for that macrovascular, those cardiovascular reduction, with a reduction in HbA1c. We've always thought of that traditionally as sort of been about the microvascular, the eyes and the kidneys. The fact it's cardiovascular as well, I think, is very, very significant.
Yeah, absolutely. And the key thing there is get in early and treat, because leaving it until the person's had their first heart attack or had a stroke appears not to give anywhere near the benefit that could be achieved from earlier. So we're going to talk a bit about Inertia, but you know, our Australian colleagues who've got a larger pharmacopoeia than us also have trouble in getting people who look like they've got poor control initiated on insulin, and the average is, of course, hiding a whole lot of reasons behind it, and probably is skewed, in fact. But you know, a good decade is occurring in many cases, and so the more complicated the treatment, there's often a longer lag before we treat, and we can shorten that if we're confident and competent with using those treatments. You know, there's a lot of interest in what delay in treatment is associated with, and there's the direct effects, I guess you might say, of better glucose control or better cholesterol control or blood pressure control is associated with better outcomes. But of course, lack of intensification or appropriate treatment is also a proxy for engagement in care, primary care, being followed up, for example, adherence to medicines, attendance in outpatient clinics. All of these are markers of patients who are at high risk. And so I think, you know, I certainly feel in my you know, part of clinical care that we have an obligation to reach out and try and make it as easy as possible to offer treatment to people, because the high risk ones are the ones that tend to miss out.
Yeah, I think that message is very much the same for general practice and community care as well, that we really need to facilitate patients having access or relationships with practices to enable sort of conversations and treatment to actually occur. And the more we drive to do that, and the more we drive to give confidence in our treatment for type 2 diabetes, I think the better off our patients are going to be.
So Brian, in your practice, you've obviously got a large population with type 2 diabetes and type 1, I assume. How do you manage that?
So in our practice, we've sort of developed, we've gone to a stage where all our nurses, so we have 8 nurses in our practice, they're all Maori and Pacific. We've all taken them to a stage where they can give basic diabetic advice for opportunistic intervention, because we've got to remember that a lot of diabetes is planned, but for a lot of diabetics, it's opportunistic. Sure. They'll present with other problems, and they present to primary care or they present to general practice for things like a skin infection or some other acute infection, but they may not be presenting for the preventative ongoing care, so that opportunistic chance. So we have a direct policy. If that happens, we can put them through to one of the nurses to start some intervention and start to build a relationship with the patient and sort of follow them up. And I think models of care are really, really important for our patients, for the way they interact, and for some patients in high deprivation areas where access to general practice may be a struggle, making it amenable or flexible to allow intervention to occur, I think, is a really critical point.
Great. great,
Yep.
thank you.
Yeah, I think those are very important, and I think there's a couple of points there I'd pick up as well. Just to re-emphasize, and Brian, you said early on that the scope and scale of this problem is too big for it to be specialist only, which I 100% agree.
Yeah.
But it's also too big to be doctor only.
That's right. Yeah.
And to the members of the audience out there who are doctors, enable your nursing staff and other staff, and work with your pharmacists in the community to help with various aspects of care. And for the nurses out there in particular, put your hands up and step forward if you're keen, and look at models that can support that sort of opportunistic thing.
Yeah.
We have to model proactivity, taking the opportunity when a person comes in with the skin infection, the gout, the urine infection, any of those events, and show that one needs to be proactive with this to achieve better outcomes.
Yep, 100%.
Okay, so patient barriers, these are things we do struggle with, aren't they? And we've put a slide up of some of those, and we've got a few other comments, some of them are verbatim comments actually from an Australian study in the following slides. But, do you want to tackle any of these?
Well, I mean, look, I think they're all realistic. I mean, fear of injections, fear of weight gain. I've had a number of patients for which it is a big, big issue. In fact, especially men, interesting enough, I've discovered in our practice, it's quite an issue. Perceived stigma, especially amongst whānau and family, can be an issue. The complexity of regimes, and this is something we'll talk to in a moment in terms of insulin intensification, that becomes an issue for some patients in terms of dealing with that and what they have to deal with it. It can be complex for some patients. And perceptions of failure, that insulin is failure, that insulin, you haven't done the right thing, that there's sort of some sort of blame game that starts to develop. We need to move right away from that. And that's why I commented early on that early on in the patient's journey with type 2 diabetes, that we're setting up the expectation this is a normal part of treatment. It's a normal part of what happens, and it's okay. The other one that's sitting there, which I think is a major one, both for clinicians and for patients, is the fear of hypoglycemia and the consequences of hypoglycemia. And I think these are all real in terms of what we see with patients on a day-to-day basis.
Absolutely, and we'll come back to the hypoglycemia one, I think, in the next slides. I just want to pick up the fear of injections. So often, I see a patient who's sent to me, it might be from their general practitioner, are there any other options? Patients reluctant to go on insulin. And I see the person walk into my room with a dark black cloud over their heads of all of this. Often their perception of injections is an old-fashioned hypodermic needle. And often they fear that it's going to be very, very onerous and difficult. And I've taken to very frequently doing sham injections on the person with their consent, of course, but actually saying, look, I don't think you do need insulin because we've got these other points, but I see this black cloud above you, and let's just put you through a sham injection so you know what we're talking about. And I can't even think of an exception where they are all surprised about how unpainful it is. In fact, I normally put it in before I've said 1, 2, and I put it in before we get to 3, and they don't even know that's been injected. And they leave the room just that little bit lighter. And again, we've sort of normalized that this might be something down the line for them.
Yep, great.
So these are some of the barriers, and you'll see fear of hypoglycemia sits in both patient factors. And I want to talk also about the doctor factors because I think that's important. But before we do, we'll just cover a few of those other things. I think we've got them before: the fear of complex regimes, fear of weight gain, fear of needles, etc. And embarrassment or stigma, as we've covered, are important patient ones. And indeed, for physicians, I think some of these are the same. I'll note the resources are a bit different, need for referrals, and we're hoping that through guidelines and these sort of webinars that we're actually giving people a way to enable to do it themselves. They don't need to necessarily ask for a specialist or one person in the practice alone who can do this. But fear of hypoglycemia is an issue, and I just want to reassure people that the sort of insulin initiation and the intensification regimes which are put forward and protocols that are put forward are inherently conservative, and the intensification is driven by doing sufficient testing to inform appropriate up titration. And the risk actually of that approach to prevent hypoglycemia is the inertia approach, the same little starting dose of insulin a year later, and we're surprised that nothing has changed. And that's a different problem. That's a barrier of I've lost confidence that my doctor or nurse, whoever is leading this work, is able to achieve for me what they said that they were going to do, and why I decided finally to take insulin. So fear of hypoglycemia is very real. It's actually very rare, that's what I was trying to say. And by being an expert practitioner in the use of insulin, and indeed with sulfonylureas, which have hypos, as Brian's given a nice example in an older patient, one can really put aside a lot of those risks. And this is some more of other things. And we put up these lists. It seems a bit onerous doing several slides on this, but I actually think the being front-footed and prepared to deal with patient concern is part of providing them good care. And I view a patient's unreasonable fear of a certain agent or misconception about what we're doing is actually my problem to solve, not a patient factor.
Yeah. And remember, sometimes those perceptions also come from the community. So we see a lot of, certainly where I am in East Pararua, families who have significant diabetes burdens, and there's these associated perceptions of treatment and what's actually going on, which are part of, again, the context of the patient. And I think I totally agree with Brandon that it's up to us as clinicians, whether we be doctors or nurses or dietitians, that we sort of tap into that, are aware of that, and start to allow the patient to express that and talk about it and move them through those barriers that may exist.
I've just had a comment from one of our viewers with regards to a potential patient barrier with the initiation of insulin. They've mentioned trying to obtain a heavy vehicle license while on insulin. Is that an issue that you both face in practice? Oh, big breath there.
Yeah, no, it is, and you know, the land transport regulations are strongly conservative about the risk of hypoglycemia, and it's very difficult to get around that. And I think, you know, people have to think about the role of their job and their life, and most of us would think that we shouldn't compromise our health in any major way through our job either. That might be, you know, by not having safety equipment or not wearing our seatbelt and so forth. If we're driving, not having appropriate protection for blood stick injuries, for example, as a clinician working in an area. And I think, you know, it's important that we put the importance of health for patients up forward. A person who's lost their eyesight and on dialysis isn't going to be driving heavy licensed vehicle, or any vehicle, in fact. And so they need to understand that. It's also a very good opportunity, I find, to review the options. And I've had a number of patients, including those that, you know, the economics are not easy, who have looked at self-funded, so in other words, non-funded treatments, which will give them good control without that hypo risk.
So these are some of the perceptions and myths of insulin that perhaps we hear in day-to-day practice. You know, I've failed. That failure message can be, my diabetes has actually gotten worse, so this isn't helping me, it's just a progression, it is worsening. I'm seen as a sicker person, less enjoyable, my health is deteriorating, I have to suffer pain, and that's, I suppose, the injection issue. I can stop watching my diet and exercise, which is an interesting one. Insulin is additive, toxic, it will make me give up. So, you know, I've failed on diet and exercise, I've failed on my medication. Now this is just the last stage, and I think, you know, these are all out there. We just need to accept they do sit around in this space, and yeah, our job is to, I think, to tap into these and uncover them and sort of demystify the myths that sit around insulin. Insulin should be viewed, I think, in terms of type 2, as we've said, as a positive going forward in terms of managing type 2 diabetes and minimizing the chances of complication.
One of the things I find in the clinicians I work with is that the more experience they get, the less they are lecturing patients about their diabetes, and the more they're listening to find out these sort of things. And so again, being comfortable with understanding the therapeutics and the agenda, if you like, why are we doing this, but not giving that as a lecture to all of our patients, like just education, but trying to understand what their concerns are with the condition. And so, for example, to take that second to last point, no, absolutely not diet and exercise lifestyle factors are critically important for ongoing control of that, and so is management of the non-diabetic aspects of a person's care, maybe the cardiovascular disease, etc. So hearing these things and being able to respond and things, I think, are very important. Okay, so this is just a point as well as not only is inertia a problem that occurs when we practice, but actually inertia is somewhat predictive of a failure to achieve better control down the line. And this is just saying that when the time is right, as one wants to act and encourage titration early in that to achieve good control. I largely think of this as a problem, not a physiologic problem, but really a psychological issue, that if a person is willing to start on insulin and the promise is better control, if one doesn't achieve it fairly soon, one sort of rather gives up. And I think as clinicians that might happen, and I suspect for our patients that's probably the case too.
Yeah, no, I agree. I think this is a really, really important slide, and I think as general practitioners in the community, one of the things I think we often tend to focus on is our fasting glucose, and that's probably a reflection of this fact that, you know, the guidelines have said, well, you know, we start with a long-acting or intermediate-acting insulin and we titrate up, and we're looking at those fasting glucose. When it comes to HbA1c, what we also have to remember is postprandial, so that post-eating glucose at 2 hours after eating and what's actually happening there. So we call this the glucose triad, and when we start to think about why an HbA1c may be up, although our fasting glucose seem to be okay, we need to start to think postprandial. We need to start to think after food, what's actually happening to this glucose levels, and are we getting what we call excursions? Are the glucose shooting very high? And that in itself is keeping the HbA1c up. So thinking about fasting glucose, thinking about postprandial or after food, and thinking about the overall HbA1c, that glucose triad, I think is a really, really important framework to start to think about what's actually happening to our patients with type 2 diabetes, especially when we start to move into the areas of insulin and what's actually going on.
A really important point, and this slide speaks to that a little bit. It's in fact, I think we cover it again a little bit later, so we'll skip it then. But this is said to be one of the most shown slides in diabetes therapeutics, and it's a slide which really has tried to estimate the contribution of fasting glucose and postprandial glucose above target levels at any given HbA1c bracket, and brings to the point that you're talking about, Brian. So it really states that, you know, when the control's very poor on the right side here, a person's likely to have marked fasting hyperglycemia, and of course postprandial will be on top of that. But most of the effort you've got to work with is in terms of pulling down their fasting, and then think about the peaks postprandially. But as you start to get people down to the sorts of targets you want people to achieve, and they're on the left side of the graph, the postprandial excursions become an increasing proportion of, if you like, the out of target and contributors to that raised HbA1c. So we're not going to have a lot of people under good control unless their postprandial targets are met, as well as their fasting targets. And that again won't only be about insulin, it'll be about the meal choice they've got, and there's a whole lot of tips and things that can be done with regard to lifestyle management, walking after an evening meal, lower glycemic index foods, spreading the calorie load throughout the day, even the order we eat the components of our meal. But insulin's obviously going to be an important part of that.
I think the other important point here, and we're going to tap into it in a moment, is the fact, if you think about your fasting glucose, that tends to be a reflection of your basal insulin, your long-acting intermediate insulin. That's what that's targeting. The basal long-acting intermediate insulin doesn't necessarily target the postprandial, and that's a really, really important practice point to start thinking about. That if that's not being targeted in a certain situation, you may not be getting HbA1c control.
Absolutely, and most practice in the past has been metformin and sulfonylureas, and sulfonylureas have some postprandial component, but it's usually when we're exhausting that insulin's been dialed in a bit late, and basal insulin buys you a bit of time in that. It starts you, if you like, starts you in the day a little bit lower. Sulfonylurea will have some extra effect, but it doesn't against the largest meal of the day, and it doesn't with a greater passage of time. Move past that. This is another thing I think, Brian, you've thought was really quite valuable.
I think this is a really, really important slide, and in terms of practice, day-to-day practice, and it's a top statement. Why not to increase the basal insulin past a certain level? So the glycemic benefit of basal insulin has been shown to plateau above about 0.5 units per kilo per day. So this is really, really important to understand, because one of the traps I think we sometimes fall into, we keep titrating the basal insulin and not introducing short-acting, but above 0.5, so if you've got someone who's 90 kilos, above about 45, 50 units, you're not going to start to get a lot of benefit from continuing to titrate the basal insulin. And I think this is something that may not be as well understood as it should be, because I know I've fallen into the trap of continuing to titrate above that level. If we're not getting benefit, we need to be doing something different. I think the other danger, and I've seen this in practice, is where we start to titrate the basal, long-acting, intermediate-acting insulin above this level. Not only is the benefit starting to plateau, and we're not getting that benefit, but also I think we start to run the risk of potential hypoglycemias. So there's a risk profile that I think starts to come into play as well. Therefore, we need to be thinking, once we get to that level, we need to be thinking about a different strategy and perhaps the introduction of short-acting insulin.
Yeah, absolutely. And so this isn't just from a single study. This has now reached, a very strong practice point in the American Diabetes Association and the European Association recommendations that one might want to be looking at mealtime insulin in one form or another. And we'll look at those different forms in a moment. This is a study which I've always found quite interesting, and it's interesting because it reflects, it's an old study. It's been a number of different published updates of it, but it's nearly 13 years old now. But it reflects the sort of environment we've been in New Zealand even more recently. So these patients all had type 2 diabetes, and it was a treat to target 4T study. Almost all patients, 95+%, were on metformin and sulfonylurea, and they remained on those drugs throughout the course of the study. And patients were randomized to either get basal insulin, prandial insulin, so just short-acting insulin, or a biphasic, so a mixed insulin. And the aim was to get very tight glycemic control. And indeed, all of these strategies were able to achieve that. But after 1 year, still remaining on the metformin and sulfonylurea, and despite titration, which was actively and proactively worked through, only a very small proportion of patients, in particular those on basal insulin, were able to achieve this tight control without having to add another insulin. So if they're on basal, they had a prandial added as second line. If they're on prandial, they had a basal added, and with the biphasic, I think the main things were to add an extra prandial at the largest meal, etc. So it became a more complicated regimen. Key point is you can achieve it by any of these, but you won't continue to achieve it by the first step. Look, we've covered this slide, so I think we might just work through it again. I think we've spoken to it already. This is a slide, we had a chuckle before the webinar came on. This talks about injectable therapy, and again refers to this most updated guideline, which has really been embraced very strongly on both sides of the Atlantic and is due for some update at the moment. But it talks about injectable agents, and the first of these, some of you may or may not recognize, a GLP-1 agonist. So we don't have any funded of these in New Zealand at the moment. That may change by the end of the year. But overseas they would consider maybe this is another option before insulin in terms of treatment. But after that, the aim is really to look at adding an insulin. And there really is a suggestion of either using basal insulin, or as we'll see soon, consider adding pre-mixed insulin. And in particular, the advantages of insulin are in those with very poor glycemic control at the time of initiation, and in particular those patients who are experiencing weight loss, so they're catabolic. Person's got the irony of having high glucose levels, but their body's not actually seeing it. It's only seeing toxic effect, not adequate nutrition in the muscles, etc.
Just a question that's come through. Someone's just wondering whether or not we can use insulin therapy in the earlier stages of type 2 diabetes to reverse and preserve the function of beta cells.
There's a few studies which have addressed this, and I have to say it looks very promising. So this is a thought that it may rest the beta cells, and so some studies have looked at adding in insulin very early from the time of diagnosis, getting very tight glycemic control for a finite number of months, just a few months, with an endpoint of and what percentage of patients will need to be on insulin to achieve good control a year later. So they come off that insulin, and then they just follow the two groups, those that were given that treatment and those that had the sham treatment. And the answer is it looks at least over a year's period of time that may give you some gain. It's not unique only to insulin. There's now another study which has looked at a combination therapy which we have in New Zealand called Galvumet, which is vildagliptin and metformin combination. And the study really targeted whether that given out front versus metformin and then stepwise adding vildagliptin later would achieve the chance of very good control, but not needing insulin as a third-line treatment. And again, that showed similar benefits. So I think the key theme in here is proactivity, getting very good glucose control early on. Even one step backwards from that, to just take that one step further, patients who have been diagnosed with diabetes and then who remit diabetes through marked lifestyle change, and this has usually been hypocaloric diets, look to have benefits which, again, are protective way down the line. And it's strange to think that even remitting diabetes for a short time may have such long-term benefit down the line.
And is there any benefit of starting a basal low-dose insulin for those who are already quite well controlled on oral hypoglycemic drugs?
I think probably not. I mean, what's quite well controlled mean, but I think if a person is at target, has achieved it with, say, metformin, maybe now with vildagliptin or one of the other agents, that has low risk of hypos, low risk of weight gain, and low side effect profile in general, I would think adding insulin is unnecessarily complex in that patient. I don't know.
I tend to agree with that. I mean, if they're well controlled on oral therapy, I'd probably just stay on that oral therapy at this point. I think on the slide there is one point to make, the GLP-1s, which we don't have available in New Zealand, and there's another class of medication, the sodium glucose transport inhibitors, which are freely available over New Zealand, may actually become available in New Zealand later this year. Pharmac has put up an RFP. I just wanted to flag that these two new classes of medication are probably going to shift up our therapeutic paradigm and what we're doing. They will be, I think, primarily in the community, and so there'll be medications that we'll need to, as general practitioners and practice nurses, keep our eyes open for, and we'll need to sort of upskill reasonably quickly. They've been shown to have possible benefits with renal protection, which I think is very important for our Maori Pacific population, and also cardiovascular benefits. So I just wanted to note that could be something that's happening slightly later in the year.
Absolutely. I think it'll majorly shake it up for our patients. So look, there are several approaches that one can intensify insulin beyond a basal-only approach. And so when we're talking about initiation, we're talking about starting the first step, and intensification is about taking that further. It's partly about dose, but as Brian's already alluded to in the earlier slides, dose of basal insulin alone will not achieve it in many of our patients. So the two broad approaches are what are called basal plus, so that's stay on the basal insulin and add an additional mealtime insulin, typically a rapid-acting insulin. We can cover why rapid-acting might be the best with the largest meal, or if the patient's been doing structured testing, a really useful thing for people to do in the meal with the largest glucose excursion. Largest meal sometimes isn't the one that'll have the largest excursion. It might be breakfast or lunch with a lot of carbohydrates, not a lot of fat or protein, rising rapidly, whereas the evening meal may have more vegetables, more protein, more fat, and delay stomach emptying. And so that's a basal plus approach. And the other is to actually say, well, why don't we just mix the insulins together? And there's some requirements for that, but give a mixed insulin. And that can initially be done in with the meal, with again the largest glycemic excursion or the largest meal, but may involve eventually over even 2 or even 3 meals of the day. And that's a pre-mixed insulin approach.
So when you're starting to intensify the insulin, there's just a question coming through with regards to how often we should be checking the blood sugars, and if there's also any comments on what you would advise for shift workers in testing.
Sure. Well, I'll kick off, and I know Brian's got some thoughts as well. So when we're thinking about a patient who's already on insulin, which is what we are with intensification, I would say the first thing is we should be doing what we think is reasonable measurement for a person on any insulin. And I think the most important one from a safety point of view is measuring the glucose before the person goes to bed. And for shift workers, that might be bed and day, it might be bed at night for most of us. That's critically important because the person is committing to be largely without any food for multiple hours following. And whilst we're asleep, we're at somewhat greater risk of having symptoms hidden. And nocturnal hypoglycemia is something that we're always very worried about and inquire about. So testing before bed is, I think, a critical one, sort of regardless of the regime that a person's on. Beyond that, testing is strongly informed really by, as we've mentioned in the slide here, looking to find glycemic excursions. And for a person who's having insulin, and in particular where there's a prandial, so a rapid acting component, be it basal plus or premixed, measuring before the meal and the insulin being given is important because that's the opportunity to mitigate that rapid acting insulin if the glucose is already low, and is also well informed by following measurements. So for example, in a person on premixed insulin taken with the evening meal, it's important to know before they go to bed what their glucose is like. Are they safe to go to bed? Do they need a snack? But also what their glucose is the next morning before breakfast. And that, if you think about what you've given the person in premixed insulin, is looking at the rapid acting component, acting over the next 2 to 4 hours, and also on the longer acting component, and looking at the time prior to the next meal over the fast, namely before breakfast. So those would be very important testing times for me in most patients. And of course, all of this is in addition to if you're unwell, in addition to if you're symptomatic.
Yeah, look, I agree with all those comments. Just a couple of additional things I'd say. Certainly at our practice, one of the things we've moved into trying to do is if we're going to make a change to insulin, or if we've got a HbA1c that's, say, staying up and they're on a basal insulin and we're wondering what to do, we're taking this approach of if the patient invests in it or allows them to do it, of a 3-day intensive monitoring. So that is, we do a before breakfast, 2 hours after breakfast, before lunch, 2 hours after lunch, before dinner, 2 hours after dinner, and we do that for 3 consecutive days, because that gives a very, very clear picture often of what exactly is going on, where the excursion is happening. It may be with the evening meal that you suddenly find the postprandial is actually quite high. It may be lunch or breakfast or whatever, and it actually informs as to what you may want to do. Now, for some patients, obviously we can't achieve that. They're very intermittent with their testing, and we have to be very pragmatic about what we're doing. But if we can do that, I find that a really, really useful technique, and one that the patient can do it for 3 days, and then they can sort of drop it, and we can make some decisions and talk about what's required at that point, whether it is some before breakfast testing, maybe 2 hours after dinner, if that's where we're going to introduce the short acting. So I think it's very patient dependent, but I think there's some good tricks. The 3-day intensive one, I think, is a really good trick, not a trick, but a way of sometimes approaching it if you're unsure of what's going on.
It is, and it also highlights some of the dietary and other lifestyle factors.
Yeah,
you may find variability from post-evening meal to post-evening meal, and that's a good opportunity to refresh about some of those principles and identify things that potentially a person may want to look at removing from their lifestyle.
Now, you may speak on this a little later, but just a few questions around the pre-mixed insulins. The first one is, how do you decide about the starting dose of a pre-mixed insulin?
Great. We've got a slide coming up very soon about it. Maybe I'll just flick ahead because we can go back. I'll just actually no, maybe it's a hidden one. So we have done there's been some guidelines written a few years ago now, which had both Australia and New Zealand primary care and secondary care input into this, which looked at really the approach for moving from a basal insulin to a premix insulin in patients in whom we thought that was useful. And essentially, I think we'll cover it in the individual cases a little bit, but essentially looks at a unit for unit approach, at least up to a certain amount, and generally for the largest meal, as we've mentioned here, unless a patient's on a very, very high dose of insulin already. And in that case, it's often best to split it. Otherwise, the person's getting a lot of prandial on one meal, and it may be inappropriate in that case. So generally up to 30 or more units of basal insulin a day, one could do this single dose premixed. If it's above that, we'll often split to a twice a day, maybe targeting breakfast and dinner. If it's a basal plus approach, normally our addition of a rapid acting insulin at one mealtime might be about 10% of the person's basal dose, or we can often start just with a low cautious amount, such as 4 to 6 units of insulin at that time, and again using testing to be able to then inform any dose titration.
Yeah, I think the key things there for me, and certainly in our practice, again, I think there's 3 things. Once you reach that sort of, as we talked about, that 0.5 units per kilo per day of that basal intermediate insulin, I think you need to be thinking about short acting. And I think a really good 2 rules of thumb. One, if you're going to go for a mix, just go for a unit for unit switch. So if it's 30 units of basal insulin, then it's 30 units of mixed insulin. I think that's a very easy way of thinking it. You won't run into too much problems as far as I can see clinically. And actually tagging that often to the evening meal is a simple way of doing it. Again, if you're thinking of adding in a basal plus, again, I think the key figure that Brandon just mentioned was 10%. So if it's 50 units, it's going to be 5 units of basal if that's what you're going to do. But we've got some cases coming up where we'll just demonstrate that. But if you think in terms of unit for unit for mix, and 10% for short acting of the total basal, then I think you to start off with, you won't go too far wrong. Yeah.
How do you decide between the two different premix options that are available?
Sure, no, really good question. So there are a number on the market, and I'm not going to favour any one particular one by brand, but make a few points. The first is that all the premixed insulins use a protaminated, so a cloudy insulin, mixed with a non-cloudy insulin. And key practice point there, and I've just come across it today, seeing a young type 1 with DKA presentation, been under services for years and still not happening, is it must be mixed. Otherwise, put the vial up to the light and it's clear at the top, grading down to being almost sludge at the bottom. So it's always got to be mixed. Otherwise, we're talking pre-mixed, but we're not doing pre-mixed. It must be mixed and remixed insulin. There is some evidence that the protaminated analog insulin, so Novamix 30 is the example there, as opposed to Penmix 30, probably has more reliable kinetics, and because the rapid-acting insulin because the shorter-acting component is a rapid-acting insulin, it is likely to have a quicker onset and more quick offset, and that's helpful, especially with the evening meal. You don't want a lot of the prandial effect running into 1 a.m. or something like that. So I've tended to do that. The other main variation is that the options, you've got a 25%, 30% and 50% mixes. 50% prandial is a lot, and I wouldn't automatically transition from basal to suddenly putting half of that dose suddenly as a prandial, as Brian was mentioning. Maybe that 10% might be. So I tend to start with things like the 25 or 30. And would only use the 50 if I was informed by testing that the person, for example, pre-meal it was a good number, post-meal 2 hours or 3 hours later it's high, but by the next morning, for example, it's normal. I would think, gee, I need a greater proportion of rapid acting without increasing the overall dose, so I've changed the proportion.
Thank you.
Yeah. So, so this is going back to perhaps just before that question, but a really important thing is just, how do we choose? Because at the end of the day, they're both very reasonable approaches. They're both supported by guidance that's out there. And this is just a list of the sort of things that might push you one way or the other. And a good discussion, I think these are sort of useful discussion points for patients. You'll see that it's individualized and it's focused about the patient. We can do that if we are confident with both approaches ourselves. Otherwise, it's going to be what the doctor likes or feels comfortable with, or what the nurse likes or feels comfortable with. So it's a bit about flexibility, the complexity, etc. And I think these are all quite important. But there's no reason, if you've started one, why you don't change to another if that other factors come up or it doesn't prove to be that useful.
I think it's totally driven by patient preference. I don't think there's any advantage one over the other. Well, there are some advantages. I mean, maybe slightly more flexible with the basal bolus, maybe a simpler regime with premix. But I think the decision as to which way you go really comes down to the patient and what they're comfortable with and what's going to really suit and slip into their lifestyle in terms of what's going on. Yeah. Now, so we've got 3 cases here, and these are real patients. Just to demonstrate, I think, the thinking that can go on. I'll get Brandon to maybe comment on some of the points here. This is the first one. So this is Theresa, who's a 46-year-old woman. She's from the Philippines. Type 2 diabetes, diagnosed in 2015. And again, a patient who visits our practice. So she's got a weight of 77 kilos, type 2 diabetes, hypertension, asthma, and significantly, I think, microalbuminuria. Let's not forget microalbuminuria. I think it is very, very significant in terms of our thinking, cardiovascular, microvascular risk, and it's something that should be infused what we're doing. She's on diltiazem, cilazapril, hydrochlorothiazide, a statin, Symbicort, and she's on metformin and gliclazide. So she's on the 2. She started her once daily nocturnal basal insulin in 2018. It was titrated to about 36 units, so she was on about 36 units about a year down the track. But her HbA1c was remaining up around 69, and this was despite she was very, very good with the diet, exercising, walking every day, and had actually been quite diligent with her insulin titration, but this HbA1c was staying up. So going back to what we talked about with the glucose triad, the HbA1c is up. Her fastings, if we look at the BSL, and I've just put an example of some of the BSL she was doing, her pre-dinner was about 6, so her fasting was actually reasonably good, and her breakfast ones were actually reasonably good as well. 2 hours post-dinner was about 12. Now we're looking for about between 8 and 10 post-dinner, so that's high. She's getting some excursion happening there. So the issue is, what do we do here? We want the HbA1c to come down. Probably the long-acting is actually working really well. We need to start to think about short-acting, and that needs to be the thinking that's going on here. So the next step, do we continue to titrate the basal insulin? Do we consider short-acting? And that's really, I think, the clinical sort of decision that we've got here.
So I guess, we're sparing the audience because they can't answer, but if we do this as a bit of a worked example and just work through some of this. So how long has she actually had type 2 diabetes, Brian? I know
she was actually diagnosed in 2015.
15. Yeah. So she's now up to her 5th year.
Yeah.
She's a woman who's probably not particularly tall, weighs 77 kilos, and she's now on pretty much that 0.5 units of insulin. And you've shown us one representative group of figures, but the pattern's similar elsewhere, that we can't drive her fasting much lower sensibly, even if there isn't that tailing off effect of increasing. Because all she has to do is go longer between a meal and she's going to get into trouble. She'll go low despite overall having poor control. And there's the solution. How could this be? Well, here we have a few hours after dinner, her glucose is high. And that's despite being on, the only other agent, gliclazide, that she's on that's going to target postprandial glucose. As you've mentioned, it's really a good time every time you see a person with suboptimal control to reinvest in checking about their diet and exercise, how they're taking their insulin, and so forth. And that's been done, a good opportunity for education. So you've highlighted this person has got microalbuminuria, and I tell patients that this is like their car is blowing smoke. The engine's still got the power to go up the hill, but there's trouble under the bonnet, the rings of the car's engine. And the good thing about microalbuminuria is it's a target to treat, but it also tells you how well you're doing. She's on appropriate renal protection, blood pressure control, we'll assume is good on all of that as well. The major thing that's going to make a difference to her risk of renal disease coming down the line is going to be improved glucose control. So she needs to have a short-acting insulin dialed in somehow.
I think that's just on that. That's a really important point. So the microalbuminuria, 3 things. 1, the ACE inhibitor or ARB is really, really important. 2, good blood pressure control is going to sort of try and slow renal progression. And 3, we now know from the latest data that reducing or getting HbA1c under better control is the 3rd thing that will influence or slow potential progression down the track to renal problems.
And there's only one other, and it's not on the slide, and probably not relevant, and that's smoking. So really important. And I think it's a number that you can show your patient, a bit like HbA1c, and say, hey, look what we've achieved by doing this. This predicts a better outcome for you. So it's a really useful tool, I think, to change behaviour or support behaviour change.
So I think the decision here is what to do. I wouldn't advocate increasing the basal insulin at this point. I think we're in a situation where fasting sugars are under good control. We're going to just increase the risk of hypoglycemia. I think short acting has to come and play. And I think simplicity is the key here in terms of our thinking and what we can do as general practitioners in the community to start this process. And so I made the point here that to titrate the glargine above that 0.5 units per kilo of glargine, you'd have to question the benefit. We saw from the slides before in the studies that there is little benefit to be gained, possible increased risk. So I think we do need to introduce short acting at this point. And I've chosen, with this woman, as we often do, kept it simple, chosen to go with the largest meal at night. We do have the reading there that proves that. And there's really 2 options at this point, and it's patient preference. That's really the thing. So a mixed insulin with a 1-to-1 switch before the evening meal. So that could be a 25 or a 30, 36 units, just a straight switch before food. There's an important point with the patient to actually remind, or to a couple of things, that they do need to mix the mixed insulin, and secondly, it needs to be before food because you're introducing the short acting, because they're used to using the glargine or whatever it is prior to going to bed, where it didn't matter, but this does matter, okay? The basal plus is to add a separate injection of short-acting insulin, and again, go for about 10% is a good starting point. So 4 to 5 units, I think, is perfectly adequate in this particular case, which is approximately 10% of your basal insulin. You keep your basal insulin going at the same dose, and then titrate depending on the postprandial BSL every 3 days, and you could make some comments on that. And also what you'd think would be a reasonable BSL testing at this point, Brandon.
Yeah, so it'll be dependent on which choice your patient's made, really, in terms of that. I think if it's the basal plus, as you've mentioned, postprandial glucose is important. Again, telling your patient that, hey, we're taking a cautious approach. We're starting this at a low dose. You'll almost certainly need a higher unit number with time, and therefore we need to test to reach that point. I think is important. And the other consideration, of course, being the safety thing. So always, if we, with either of these 2 intensification approaches, we would still be wanting to measure the postprandial evening, because they've said it's an evening meal, and that's coincidentally the before bed one, which is, I've said, is that key safety measure. And I say to patients, when you go to bed at night, do you lock up the doors? And yeah, I check the doors and the windows are locked. And I say, why do you do it? And they acknowledge, you know, bad things can happen at night and you're asleep and your defenses are down. And I say it's exactly the same for when you're taking insulin, for example. You need to know before you put the place to bed for the night that you are in a safe circumstance.
Yep. And I suppose the other comment is your target for your postprandial, you're aiming for about 8 to 10?
Yeah, 8 to 10, and not tighter than that, in particular not tighter than that.
Yep.
Pre-bed. The guidelines, various guidelines around the world, have generally said anywhere between 6 and 10 is reasonable, 2 hours. If you're ending up using higher doses of insulin, much higher than, say, the 4 units of the prandial part, the duration of action of the short-acting will actually become a bit longer. And I would then, if possible, even look out to 3 hours post,
right?
Especially when safety is the key thing, because there's still quite a lot of activity of that short-acting insulin.
Okay, good. Just a couple of comments just to focus again. I think practice points. When you're introducing the short-acting, continue the metformin, really important message. But with the short-acting, you can start to taper the sulfonylurea, the glycoside. So generally what we do in our practice is introducing short-acting, say at an evening dose, we'd start to halve the sulfonylurea on the evening dose and then possibly take it out, but maybe leave the morning one going. If we were to introduce short-acting in the morning, we'd start to taper off the sulfonylurea. I don't know if that's a reasonable approach.
Yeah, I think it is. I mean, I've tended to not stop at that point, again, sort of tapering or at least indicating that we're going to do that. Once you're on twice a day, prandially based, be it a basal plus or a mixed, once you're twice a day, I think most of us have put up the white flag and said, hey, we're now targeting prandial excursions with insulin. Sulfonylurea is the reason we've got to this point, is sulfonylurea is not working. And again, that's when we've already got the basal dose already optimized and their fasting's looking pretty good. We're basically saying sulfonylurea is just not working.
What about vildagliptin? Would you keep that going?
I probably would at the moment, for a couple of reasons. One is it's a way of being able to give, it's got no added hypo risk associated with it, and it's a good way of giving patients metformin at a lower pill burden than they currently have.
Okay.
There's not a lot of information to guide us, as you're aware, Brian. The information around vildagliptin is actually relatively modest of all these agents. And it's probably more a early initiation treatment. I think 75% of people with type 2 diabetes in Japan are on a DPP-4. It tends to be used early and phased off. I wouldn't strongly want to keep them on it.
All right. So just the other things to remember, that improving the HbA1c reduces the complications for both microvascular and macrovascular, which is very, very important in this particular case. Patient preference, I think, drives whether you go for a mixed insulin or a basal plus regime. And there is little additional risk of hypoglycemia if you introduce short-acting in a stepwise manner. It's a perfectly safe thing to do, and I think that's a key message.
Absolutely.
Okay, so this is Murray. He's 38-year-old European male, type 2 diabetes, diagnosed in 2012. So again, he's got hypertension, COPD, hyperlipidemia. He has had a past MI, and he's got microalbuminuria as well. Again, we've got him on an ACE, a statin, aspirin for cardiovascular protection. He's on an inhaler for his COPD, metoprolol, obviously past MI, and he's on metformin and gliclazide. He started his once daily nocturnal glargine in 2015. His basal insulin has again been titrated to about 38 units at night. His most recent HbA1c is 74, and that's despite efforts with diet, exercise, and insulin titration. I'm not convinced about his efforts with diet in Murray's case, but yeah, we have long discussions about it, but this is persistently high HbA1c.
Yeah, so I mean, this is a really concerning case, isn't it?
Yeah.
A young guy, and already he's got overt coronary disease.
Yeah.
And presents with the sort of the triad of factors that we see: high blood pressure, dyslipidemia, overt coronary disease, and renal disease. And one really wants to exact as good control as you can on this guy. So unlike your last case, he hasn't presented us with some BSLs, and I think that would be very helpful to know that. It will help him understand why one might want to change from the current approach. He'll see the variability in his glucose, presumably, or maybe his variability in his sticking to his diet.
I just realised I've got 38 up there. He's actually 58.
58, oh.
Sorry, I just sort of looked at that and thought, no, he's not 38. He's in an EMI. He's 58, sorry.
58. It's still pretty concerning.
Well, it's concerning, it doesn't obligate anything that you just said, but he is 20 years older.
So I mean, this chap presents many of the other challenges as before, and of course, as clinicians, if we're being very proactive with patients with diabetes in terms of the cardio-metabolic control, many of the themes are going to be common, aren't they? But again, this guy is on fairly generous amounts of basal insulin. He's again been established on the oral agents, and those have been up titrated, I'm sure, to maximum tolerable or maximum effective doses. And again, one's refreshing always about doing the right things. You have some concerns with them, but it is what it is. One's got to act still on this.
Yeah. And
so I'd like to see some BSLs. I'd like him to understand his diet a bit about what the biggest meal is he missing meals, etc. And then I think one's probably going to want to be adding in some prandial component.
So again, similar sort of thing. Again, the point about the 0.5 units per kilo, there's very little benefit once we start to get to this level. We could consider a mixed insulin regime at 38 units, or 40 units, just before his evening meal. BSL testing is problematic with Murray, I've got to say. So yeah, if we can get him to do a little bit around that time, just try and pick what's going on. As I said, the other approach, if he was more amenable to it, would be a 3-day, 6 times a day intensive BSL testing to really get a picture of what was going on. Again, the 10% short acting we could introduce as a basal plus regime, so about 5-6 units, and start to titrate, looking at the postprandial BSL, and we again titrate based on the BSLs. Have you got any comments about the titration on the BSLs and what what we're sort of basically looking for in terms of the BSLs?
Sure.
Yeah.
So I'll pick that up, and then I just want to make a comment just about the choices in a person like Murray.
Yep.
So the approach for up titration of basal insulin, up titration of short-acting insulin, and up titration of mixed insulin is very similar.
Okay.
It requires testing to inform it, so there's no blind up titration, so it's naturally safe. And it typically takes the approach of up titrate on what the lowest glucose value is.
Right.
So if a person has got, and I'll just take a basal example because it's quite easy, but let's say a person's before breakfasts are 6, 10, and 12, one will not up titrate the basal because of the 6. The 6 is in target.
Right.
So it is naturally inertial in a way that's protective or prevents hypoglycemia.
Right.
Because you've got a chance again, and it turns out that 6 was the total out of the bag one, and every other value is in double figures. Well, then you'll up titrate them. So every 3 days, a maximum of twice a week, essentially, over any particular dosing time, is the sort of rate of up titration that can be achieved. And interestingly, in some studies that have looked at this, giving a patient that sort of schedule with a little if greater than increased by 2 units schedule and doing it twice a week allows more rapid and equally safe titration as reporting to your general practice once a week. And the reason, of course, is it's happening twice as frequently. So for activated patients, this is something they can very much do themselves. I was going to just make a comment as well about the choice, and it's Murray's choice. But one of the advantages of having a basal plus, and ultimately it may be a full basal bolus, is that it's highly flexible. What size meal am I having? How high is my glucose before this and only this meal? And making adjustments, so a correction and an anticipation on the meal. So one of the advantages is doing that, and we encourage that, of course, for people with type 1 diabetes as the norm. But if a person's not testing much, the advantages of the flexibility ultimately from meal to meal of a basal bolus regimen is limited. And so for a person that's not going to test a lot, maybe beyond some early stabilization, as you've discussed, a mixed insulin may offer just as much advantage without any added burden of doing lots of sugar testing.
And certainly in Murray's case, he chose a mixed insulin for that very reason, and he didn't want 2 injections at this point, and that was fine, and we just moved him on. So again, it's the same real messages. Continue the metformin, taper the glycoside became the other issue here. Remember the microvascular, macrovascular patient preferences we've just discussed is critical, and there's little additional risk of hypoglycemia, and I think that's a really, really important message when we start to consider these patients. And he's 58, not 38. Okay, so this is James. He's 48-year-old Maori male, type 2 diabetes, diagnosed in 2009. Okay. So he's 120 kilos, is on a basal insulin regime. He's up to about 60 units. Is hypertension, hyperlipidemia, and again microalbuminuria. He's on vildagliptin, metformin, pioglitazone, an ACE statin, and aspirin at this point. He started once daily nocturnal basal insulin in 2014. It's been titrated to about 60 units, and his most recent HbA1c is 80. Again, despite discussions about diet, exercise, we have managed to slowly titrate the insulin. It has been reasonably problematic. But again, we're left in the same position as to what's the safe thing to do here. He's on a slightly higher dose of the basal insulin, up around 60, which again is about 0.5 per units per kilo. He's 120 kilos. So again, we need to start thinking about short acting in this situation.
Yeah, so it's interesting. So here's a patient on pioglitazone, which I think we've talked about in other meetings before. That's very much our minority practice, but this is an insulin sensitizing agent. Its value in terms of lowering glucose is broadly proportionate to how high the person's glucose level is. That's true for all agents. So higher HbA1c, you get a greater drop. but it's also associated with some weight gain, which is partly real, partly fluid in patients, and one you'd wonder a little bit about with hypertension.
Yep.
It's an insulin sensitizer, as I say, but I think its prescription use in New Zealand is very little.
Sure.
You're already trying to deal with his other risk factors. He's on ACE inhibitor, statin, and aspirin. He's not on sulfonylurea, he's on vildagliptin, so this is obviously right up to date. We've only had this agent for 15, 16 months.
And again, the reason he went on to vildagliptin was to reduce his pill burden in this particular case.
And I think that's really important. The pill burden is quite a lot if you start adding all these up. So, I guess the similar risks, this chap's glucose control is even poorer. And again, I always, just to go over that same point, is always check adherence. It doesn't matter what regimen you're on. If you're not adherent to it, it's not going to work. And there's many reasons for that, such as a side effect. He went hypoglycemic on the agent, or he doesn't like the weight gain, or some of those conceptions and misconceptions about things. We have advantage where I work in a hospital that when a person seeing me in clinic, I can see all of their dispensers. And it's amazing that the dispensing record would suggest that they could only possibly have had 30, 40, 50, 60, 70% of the dose that they're on. And it's a good point for discussion about that. But let's assume that his adherence is totally reasonable. It's at this sort of level with an HbA1c of 80, even if you weren't on insulin, so you were insulin naive, but starting insulin, you'd look at that number and you'd say, probably needs to have a prandial component dialed in anyway. He's already getting plenty of basal put in, and so it's even more obvious that he must have some prandial. And I would think when you're at that sort of level and needing large amounts of insulin, I would go a bit further with pill burden and probably cross off the pioglitazone and get into insulin again with a patient choice driving which of those two pathways one might take.
So again, the point about the 0.5 units per kilo of glargine, questionable benefit and risk with hypoglycemia, perhaps, if we keep pushing that dose. He's at risk, his HbA1c is reasonably high. He's got these risk factors that are rolling around here, including the microalbuminuria, hypertension, hyperlipidemia. So again, we've got two ways to go here. The mixed insulin, again, we could go for a 1-to-1 split with the 60 units to 60 units of mixed insulin. And one of the options here, and perhaps you want to talk about that, Brenda, is to actually split the dose 50% in the morning, 50% before, in the morning before breakfast, and 50% before dinner. Which is, I go for simplicity in these situations. That's what I tend to do to start off with before we start to look at them. But I don't know if you've got any comments about that.
No, I agree. And we mentioned a little earlier that when a person's on a large amount of insulin, and we are looking at now or translating some of that into prandial, it's probably not reasonable to put all of that onto only one meal. So this guy's, as we see, on 60 units, and I think splitting to 2 injections, great. And if that's known at the beginning that in this person's case, putting him on a mixed insulin isn't keeping him on 1 injection, and what the reasons for that, so that he understands that the choices are twice a day. You will undoubtedly need that. The other point to make is there's only so many units you can give in a single injection anyway. This guy isn't actually having 1 injection. He's having a 60-unit dose made up of two injections at the moment. So he's probably familiar with that anyway. But I think to spread it out is the right thing to do. And unless informed otherwise, the safest thing is not to stack it one end or the other. So I would go down the middle as you have, but tell them, hey, it'd be miraculous if it stayed at exactly the same morning and evening, and we'll refine that with time.
And again, over time, we're starting to look at maybe some of the fasting sugars and some of those 2-hour post-prandial sugars to start to make adjustments based on the readings and taking into account the thing that you mentioned, that you're looking at the lowest reading, especially for fasting.
Absolutely. So this sort of 1-to-1 switch with both breakfast and dinner is really easy. The pre-breakfast tells us about what the dinner dose the night before did. The pre-dinner tells us about the breakfast dose. And those 2 values for control and before you go to bed for safety, even if just done intensely for a period of time, are really helpful to get that titration working.
Right. So again, the basal plus approach, again, think about 10% as a reasonable starting dose. 6 units are short acting. Again, before dinner becomes the important message, and it does for the mixed insulins as well. So 6 units before dinner, and which is approximately 10% of your basal dose, and begin to start to look at titration, because again, titration becomes the key here, based on the BSLs.
So you've highlighted it, and I can't put it better, but I'll give a little case. This is a true case. So it's a woman who was about 60-year-old Pacific Island woman, was admitted to hospital with severe hypoglycemia. She recovered, had no long-term consequences of it. And in trying to work out what had happened, she had recently been changed from basal insulin to a premixed insulin. She had not been educated, as she tells it, about the mixing of the insulin. And so highly likely she got a whole lot of rapid-acting insulin. But she also hadn't been told about this is now a mealtime insulin.
Yeah.
So before she went to bed that night, instead of having, and I'll just make the number up, 50 units of Lantus insulin, she got 50 units of some premixed insulin. I won't claim to remember which it was.
Yeah.
And a predictable thing happened. So the education around this is a really important subtext to all of these things that we're talking about.
Okay. So again, same practice points, continue the metformin, taper the glycoside with the introduction of the sulfonylurea, although he's on vildagliptin, in which case we probably just keep that going because of the bilgurden, but again, we could take away the pioglitazone. Remembering improving HbA1c is both microvascular and macrovascular. Patient preference is a driver here in terms of what's going on, and there's little risk of additional hypoglycemia. Taking into account those very important practice tips about we need to be very clear about when the insulin is taken, which is before meals, and if it's a mixed insulin, that mixing and that cloudiness becomes a really, really important part of what's going on.
So look, we've just put a few summaries down here, which I think just cover broadly the philosophy of therapy of people with diabetes. And we're focused in this talk, obviously, mainly about glycemia, but as we've highlighted in the cases, there are many other aspects to patients' care. So it's a progressive disease, and many patients with type 2 diabetes will need treatment intensification. And as patients develop this condition younger, and those patients who have high vulnerability to the effects of diabetes, in particular Pacific and Maori patients, they will likely need treatment intensification, including insulin, throughout their lifetime. A lot of patients currently, and internationally we see it, but actually New Zealand statistics look worse than our Australian colleagues in this, experience poor glucose control, and that exposes them to increased risks of complications. The HbA1c conveniently gives us a sort of a 3-month snapshot, and our prescribing practice in New Zealand, unlike Australia, is 3 months, except for contraceptive pills, of course. And so the 3-month interval is a very good opportunity to reevaluate and be quite proactive, I think. I'm sure it's something you do. We talked a bit about enabling other members of the practice team to be able to do this. If we leave it just to doctors, we're going to get hammered. And I don't know about you, but I didn't get trained to be an expert actually at management. We're often diagnosticians, aren't we? And a lot of the management thing is the person that they know. It could even be the practice manager or the receptionist that knows them and their lives, the practice nurse who's taking the opportunity when seeing other members of the family doing immunisations to use those opportunities.
And let's not forget our nurse practitioners. They're coming to the fore now, and our specialist diabetes nurses as well. Absolutely.
And so I think nurse prescribing in New Zealand, both for nurse practitioners but also for nurse prescribing in other settings, has been a huge bonus. We utilise it a lot in our secondary care environment, and I think in primary care it's increasingly there, not only for diabetes but across a whole lot of chronic diseases. Absolutely well put point, I think. And of course our pharmacy colleagues as well, who are often following up with patients, and maybe the first person to note that the person's not picking up their insulin at a frequency similar to that you'd expect along with their gout medication, or vice versa. Brian, you highlighted the importance of choice is important, and so intensification is the agenda, but there is choice for patients.
Yeah. I think the only other things I'd really want to add in here before we go to questions and things is I think as practice points as clinicians, remember that triad, HbA1c pre-prandial, post-prandial. Just remember that sort of keeping to titrating the basal insulin past a certain point, that 0.05 is a great figure to remember. There's probably very little additional benefit. And I think for me, adding short acting, if you take a stepwise approach, with one meal at either 10% of basal or a 1-to-1 mixed regime. It's actually a very safe thing to do in terms of hypoglycemia. So it's something we can do, we can achieve, and we can sort of move the patient on quite easily. And patient choice becomes a critical issue.
Great. Thank you very much for your thorough and the practice tips that you've given us. It's been really useful. We've actually managed to answer most of our questions along the way during the course of the discussion, which is very handy. We've also run a little bit over time today, so we'll probably end up wrapping up our webinar here tonight. So once again, thank you very much for coming in and having a fantastic talk. I've learnt a lot tonight. So thank you very much, everyone, and good night.
Thank you. Good night.
Thank you.